Hello, my name's Marc Ryan. I'm the Chief Strategy and Compliance Officer at MedHOK, and welcome to one in a series of podcasts. Today's topic is the Emerging National Model of Care. Most of you are very familiar now with the fact that the model of care is a very important element for special needs plans in the Medicare Advantage program, as well as the Medicare Medicaid plan environment that are ongoing now in a number of states. However, CMS is actually working on using the same concept of model of care and extending it throughout every line of business in their national accountability approach for healthcare. This slide is sort of a rough explanation of what we see happening over the next several years in terms of bringing this emerging model of care to all lines of business. Let's look at the left-hand side first and think about some of the tenets about why this really is an important element that CMS is looking at. Number one, as we're all very aware, utilization management has long dominated the approach to U.S. healthcare. Going all the way back to the introduction of the Blue Cross and Blue Shield associations, healthcare has been dominated about limiting costs overall in really two ways. One, can we find network discounts out there by guaranteeing providers volume? And number two, over time, by having health plans, especially in the 1970s as managed care had its advent, finding ways to assess whether a given healthcare service is truly needed by an individual. CMS is finding that this approach to healthcare is really creating a lot of gaps in not only the quality of our care, but is not really limiting overall costs. It may limit costs related to individual services because we're looking at the medical necessity of those costs, but in the aggregate, it's not really limiting costs overall in the system. Number two, it's also known that the U.S. has among the lowest outcomes in a number of measures when it comes to all OECD nations. The OECD nations are those that are fully developed and have fairly sophisticated healthcare systems. And in this case, if you look at these measures, we rank extremely low, again, in a number of different areas. Number one, if you look at a number of prevention scores, we rank near or at the bottom on prevention in our healthcare system. Number two, we also have very high hospital costs on the other end of the spectrum. Number three, we have extremely high readmission rates. And these readmission rates are high on a series of common disease states and chronic comorbidities that could be managed in a community-based setting, in a preventative type setting, as they are done in many OECD nations. And lastly, we have very little care coordination compared to other OECD nations. And again, that impacts how high our readmissions rate is as well. So in a summary, very little prevention, very little care coordination, which leads to the use by Americans of services really at the very high end of the healthcare system, the costly end and the end that is really more reactive than proactive. In addition, the multiply comorbid are a disproportionate share of our overall costs, and that is the case, obviously, in all healthcare settings, but when you don't manage these populations correctly, it means that the multiply comorbid take on a greater and greater share of the overall healthcare pie. CMS believes that if we emphasize care coordination, prevention, and quality outcomes, we can reduce the cost curve we're seeing today in our healthcare system and improve the very lackluster quality we see when we compare ourselves to the OECD nations. So, in summary, CMS really wants a model of care that is attributed in some form to every member in all lines of business. And we'll talk in a couple of minutes about what this really means. Let's look in the middle category here about a couple of the initiatives that CMS is taking or are ongoing in an effort to really introduce this emerging model of care through all lines of business. Well, first, they have spent a lot of time reworking their approach to the Medicare Advantage special needs plans. And this is a very important element of their effort to really define what this national model of care will be. It wasn't too many years ago that SNP plans were sort of on their deathbed. They survived by last-minute extensions by either CMS or by the Congress. And now we are in a stage where CMS is really endorsing special needs plans as a way of really limiting costs and improving quality in both the Medicare and the Medicaid worlds, and both in the acute care world as well as the long-term care world. And the model of care has become entirely refined. You now have to get that approved initially and on an ongoing basis. And the audit regime in the approach to the model of care is also being strengthened over time as well by CMS. So very serious attention to special needs plans. We're also aware that they're sort of cousins of the special needs plans, the Medicare Medicaid plans, or the dual demonstration program is now firmly underway in about a dozen states or so. There are some capitated pilots with health plans, and there are some fee-for-service pilots as well. But at its core, these MMP plans are supposed to build on the advancement we've seen with MA SNPs in general, and really firmly link and integrate the Medicare and the Medicaid funding streams and the programs over time. These MMP plans are taking a couple of different forms in the marketplace. In some cases, they look much like just an acute Medicare and acute Medicaid service integration. But in other states, like in Massachusetts, for example, it goes beyond the acute Medicare and Medicaid integration to bringing in those very important full Medicaid long-term care acute care services into the model as well, to have a really major look in integrating both acute and long-term care Medicare and Medicaid funding streams. CMS is not really stopping at these dual eligible type populations in their effort to really bring a national model of care to all lines of business. They are also paying some attention to what we call the mainstream Medicare Advantage world, those that aren't special needs plans, but we know that there are individuals that are significantly comorbid in these populations. We know that the disproportionate share, again, of resources are not only spent on dual eligibles, but are spent to even a greater degree, in excess of 90%, on those with 2 or more disease states. So if we can begin to look at those with 2 or more disease states and treat them in a very different way and bring quality to their experience, we could again also reduce that cost curve. So in an effort to get to those that don't go to special needs plans, CMS is also introducing what's known as the Value-Based Insurance Design Initiative that is being piloted in a number of states out there, roughly about a half a dozen. In this case, what CMS, beginning in 2017, and filing has already been done by those plans that want to participate, CMS is asking plans to create a sort of subset for a subset of their population, reduced cost sharing and enhanced services, especially in the area of care management, to see if that can positively impact not only the cost of these populations, but also improve the quality. Now, the truth is that there's very little incentive for health plans to necessarily join this initiative. There's no additional funding or anything of that nature. And the administrative costs, admittedly, of this are going to be fairly big for plans. But for those plans looking at doing this now and in the future, it is going to be a great barometer to see how care management programs, reduce cost sharing, and bringing other value-added services and even some incentives to the table could positively impact medical expense bottom lines, as well as also improve quality. So we see this as an initiative that's going to morph over the next couple of years as we get some of the results in from 2017 and perhaps in 2018 to bring even more innovation to this value-based insurance design. Moving outside of the Medicare world, we're now going to take a look at Medicaid, and this emerging model of care in all lines of business will also begin to impact Medicaid. As you're also aware, CMS has been extremely frustrated by the lack of accountability and the lack of quality in the Medicaid world overall. While some states have been extremely progressive and have put in quality assessment programs and have been very accountability minded, for example, New York and California and a few other states, by and large, since managed care was introduced even several decades ago in a number of states, that accountability infrastructure and that quality infrastructure has really lacked at the state level. So CMS has been working with states to demand much more accountability and quality orientation in the Medicaid managed care world and even in the Medicaid fee-for-service world. And the biggest threshold change here has been the final adoption of what's known as the Medicaid Uber rule. And this Uber rule will really change the entire landscape to Medicaid. It will bring the same kind of Medicare and Medicaid accountability to the Medicaid world as it does in Medicare. In this case, part of that Uber rule focuses on sort of a care management approach for all Medicaid members. And while this has been the case to some degree, the Medicaid Uber rule really institutionalizes this approach. Initial assessments will have to be undertaken in good faith for all members. It's not an explicit mandate, but it comes at least closer to that. So all members enrolling in Medicaid will have to have an initial assessment on enrollment. In addition, in an effort to sort of stratify and focus in on those that are more comorbid and riskier, you'll also have to have additional complex assessments and ultimately treatment plans that look a lot like the interdisciplinary care teams in Medicare for those that are more complex in the Medicaid program. So again, here, CMS in the Medicaid world is trying to focus on some sort of assessment on all members in Medicaid, and for those that are deemed much riskier and more complex and comorbid, additional assessments and a mandate to have treatment plans for that subset of individuals in Medicaid. And lastly, in the center column here, we know that CMS, as a companion to this model of care initiative, is really trying to introduce STAR or quality incentive programs throughout all lines of business. We've talked a lot in our blogs as well as in our earlier podcasts about the success of the CMS Medicare and Part D STAR program. It has driven quality to the extent that now about 71% of MA members are in plans with four and five stars versus as little as a quarter just in 2010. This same kind of STAR program will roll out to Medicaid. The Medicaid Uber rule dictates a STAR program in every state, either one that the federal government will set up that will look a lot like the Medicare Advantage program, or one that passes muster with CMS that is set up by the given state Medicaid program. And lastly, we know even in the exchange world, this STAR program is coming there too. CMS will pilot for the federal exchanges a STAR rating program in a small number of states in 2017. In the future, that will go to all states, and over time, we'll see again quality-based reimbursement in the exchange program. Let's look at what the future state of this emerging model of care in all lines of business will look like. And here are a few areas that we think CMS ultimately will focus on. Well, number one, they want, as we've already suggested, a model of care in some form for every member in each of the lines of business, Medicare, Medicaid, and exchange or commercial, based on the member needs. This could be socioeconomic in nature. This could be health literacy in nature. This could be based on disease states of that individual. And lastly, this could be based on the financial and service risk of the individual. So one or more of those things will have to be taken into account for the types of interventions and for that individual model of care that every member will have. CMS will also be looking for the plan to have the ability to tailor multi-tiered care management intervention and plans based on that risk assessment we just talked about and that stratification of those members. So, for example, CMS is not asking that everybody have an individualized care plan or be subject to some sort of complex care management program. We never would have enough money for that. But they are looking for a stratification and tailored interventions, either on a group or an individual basis, as necessitated by the financial and other risks of that individual. They're also looking clearly to tie quality assessment and programs into that model of care system. And that would mean looking very strongly at care gaps of individuals. And they'd like to see those care gaps triggered into whatever kind of care plan or intervention strategy that that individual has. Lastly, communication to members on this front is also very important. So CMS is going to want to see communication on an ongoing basis to these individuals. So they would like to see, again, initial assessments in some cases. They would like to see ongoing assessments as needed as risk may change for that individual. They would like to see health education, probably on almost all individuals. They'll like to see disease management, either on a group basis or perhaps on an individualized basis, depending on the comorbidities of that individual. Again, they would like to see care gap closures focused on all individuals. And then, of course, on that 5% of less of that population that have significant complexity, they want to see this complex case management with full interdisciplinary care teams and individualized care plans for those individuals. Very similar to what we see today in the special need plan world and in the MMP world. And lastly, care transitions. Care transitions are taking on significant importance, and CMS wants that to be a focus really across the board when somebody is going into a high level of care or is moving from a high level of care to different levels of care. They want that person closely tracked to prevent readmissions and to ensure quality outcomes moving forward. CMS is also going to want to see integration of medical and pharmacy care management. Traditionally, we've sort of seen medical and the pharmacy side split, but as pharmacy quality measures take on a significant importance and the need to have medication therapy management on broader populations, they really want to see medical and pharmacy come together in one intervention strategy or care plan. And lastly, there's going to be a significant emphasis on self-directed care and self-managed care. What do we mean by these two things? Number one, self-directed care will be the ability to empower individuals that are in need of intervention strategies to basically self-direct that care, where they are given the ability, the empowerment to have funds to allocate that basically meets their human needs as well. And second, what is self-management? In this case, CMS really wants plans to challenge individuals to really be a stakeholder in their care, to actually self-manage certain problems, goals, and interventions that they can take hold of and they can actually carry forward. Not everything will be a self-management goal because it will need the input of providers and other members of an interdisciplinary care team, for example. But to the degree that you can self-manage certain areas, including maybe your disease states and things of that nature, CMS will want plans to pursue that goal as well. So that's sort of a wrap on what we view as the emerging model of care in all lines of business out there. We hope you enjoyed this webinar. We'd like to talk briefly about MedHOK. MedHOK stands for Medical House of Knowledge. We offer a SaaS-based software platform that enables health plans and payers to simplify compliance, control member care and coordination, and succeed in the emerging value-based healthcare world. We are out-of-the-box compliant and proactively updated for Medicare, Medicaid, and exchange regulations. You can learn more about us at www.medhok.com. You can subscribe to our blogs as well at that website /blog. And you can also visit us at MedHOK University on YouTube. Our last slide here shows all of the all of the solutions we offer within this one single software platform in the areas of risk management, care management, and quality management. Thanks again for joining us. Take care.